my job is to teach you how some of this basic science and legal background can be applied clinically. Just 2 seconds about myself. I supervised a group of cannabis clinics in California that saw 300,000 patients. And we did a demographic study, and we compiled a lot of data about how people were using medical cannabis. And a lot of that is given to you in a book that I've written that's also came out this year, and Medical Cannabis Pearls for Clinical Practice. And I believe, I'm not sure, Dr. Sulak may know more about this. We're going to have a book signing at some point this weekend with his book and my book, both excellent medical reference texts for you. So we will begin. So what do we need to know to be a cannabis clinical specialist? And in many states, these are MDs and DOs. In some states, there are family nurse practitioners and physician assistants or pharmacists that are legally designated as the gatekeepers to know about how to provide cannabis medically and legally. So, little aside, on my feedback from the CME approval accreditation people, they didn't like this slide. And they said, what do you need that for? It's not about cannabis. But we're trying to learn what's important in understanding how to recommend cannabis as a clinician. And these particular skills that I've listed here are all really essential, so I want to review them. You do need to know how to evaluate medical history documents and extract the information from them about which medical conditions you're treating. It's not enough for the patient to come in and say, I have a problem sleeping, because the patient may not realize that their rheumatoid arthritis or their depression or multiple other conditions that they have are also appropriate for cannabis treatment. So you need to determine that, what their conditions are. For legally, also you have to do an appropriate exam for the diagnosis. That's the history and the physical. Specifically for cannabis, because it has been shrouded with some secrecy and some doubt and has a stigma, it's important to put patients at ease and counsel them about the medical benefits. Very often, you're the first person that is in a position to help the patient understand how to use a substance that they've been using recreationally as a medicine. It's one of the most important skills that we have to do. If you don't document it, legally it didn't happen. So you have to document everything that you talked about, the advice and consent, the informed consent, the risks and the benefits, why you're using cannabis, what treatments that what conditions you're treating. Most states, as part of that Federation of State Medical Boards, also ask you to put in a treatment plan and referral sources for ongoing care. And then, of course, what we're going to learn about today, expertise in the clinical use of medical cannabis for a multitude of conditions. So moving on to expertise in clinical cannabis, there's a lot to know. And unfortunately, in the history of cannabis healthcare practitioners who sign the recommendation paper, they don't know this stuff. So it's really important moving forward as we hone our skills for the cannabis clinician specialist to know what we did earlier, the basic science of cannabis chemistry, the endocannabinoid system, cannabinoids, terpenes, other components of the plant, treatments that you need to know the effect of cannabis on body physiology, organs, and systems. One particular interest of mine is understanding that cannabis sativa is an herbal botanical product. It's not a pharmaceutical medicine. And when you dose it and you discuss, delivery and follow-up, you have to learn a little bit about how to do herbal prescription versus pharmaceutical prescription. And that's not something that is taught in medical training, but we do teach it in cannabis training. For your state, you need to know which medical conditions qualify. You need to know your laws. And after all that, you need to know what works with dosing, and that is very individualized, and each patient is different, and Dr. Sulak's actually going to talk about that during the conference. I have put in here also, for me as a practitioner, the effect of cannabis consumption at chronic versus naive or acute dosage is completely different, completely. So you need to know both ends of the spectrum. What is your naive patient going to experience, and what is your chronic consumption patient going to experience? Which brings us to the issue of tolerance, overuse, and knowing about dependence and the cannabis withdrawal syndrome. And there's always lots of sources to learn from. There's many good CMEs available online. There's this conference, and I encourage you all to try to learn what you need to learn to cover this page. Because we're in Missouri, I have listed exactly from the internet what patients need for a Missouri certification. I don't think that I will stick with this and move on because each state is different. But there, as Cynthia said, there is a Federation of State Medical Board guidelines that's supposed to guide all states that have what you need to know and how to do an appropriate certification. So the qualifying conditions, for example, in Missouri, they're different for each state, are these listed here. I want to point out, because it's important in the next slide, that it's down like third bullet point from the bottom. A chronic medical condition that is normally treated with a prescription medication that could lead to physical or psychological dependence. They're talking about the medication. And that cannabis in that case might serve as a safer alternative. That's the entire area of harm reduction. That cannabis replaces prescription medications, drugs of abuse, alcohol, tobacco, in a much safer way, and that's what we do a lot in our work. And then there's many other conditions here. I want to move on to, okay, in a minute, I'll move on to the 10 most common conditions that we see nationally. But moving on with Missouri, we see that the highest percentage of patients in Missouri, 30%, use cannabis to treat this physical or psychological dependence. And I had to really look that up because I said, are they talking about cannabis dependence here? No, they're talking about harm reduction. Then chronic medical conditions, 28%, psychiatric, 17%, migraine, 6%, terminal illnesses, 3%, and all the other conditions, 16%. So if we go back and we look at this whole long list, we see that it's the chronic medical conditions and their treatment in standard medicine that actually cover most of what cannabis is used for in this state and in most states. Oh, age. So Missouri is not necessarily the standard for the whole country, but we see that the majority of patients in Missouri are between age 30 and 50. Some states, the younger population, 18 to 29, have a higher precedence, higher numbers. We also see that minors under 17 is only 0.31%. In some states, it could be up to about 5%. So it depends on how familiar the physicians are that are recommending this product with working with different age populations. And that's what my talk's going to be about in a couple of days, working with different age populations. The more familiar that a clinician specialist becomes with working with different age populations, the more comfortable they are recommending cannabis for that group. And we do see that elderly people, seniors and above, are here 22% of the population. And that's another interesting statistic, that the use of cannabis by seniors, especially since CBD became more widely available, has been rising as the fastest growing group. Okay, so statistically, pain and chronic pain is the highest percentage of usage of medical cannabis anywhere in the country, in all states. Then, depending upon what is approved, insomnia generally comes next. Some states do not approve insomnia, such as Missouri. So we don't see statistically that number is recorded, but in most states that do approve insomnia, that's the next one. Then we see mental health, depression, anxiety. I added PTSD at the end, but in states that approve it as a specific condition, it could be very high. For example, in my state of New Mexico at the moment, PTSD is the highest mental illness category because they don't approve depression and anxiety. So you have to be really creative if you're a physician in how you diagnose your patients so that they can qualify. Following the mood disorders, pain, and insomnia, then we find muscle spasm. In some states where that's specifically a diagnosis, it's very high. Then headache, migraine, nausea, cancer, and anorexia, and included in all that are the side effects of many chronic conditions. You know, anorexia and nausea and pain are part of most debilitating chronic conditions. So we really need to know how cannabis works with those conditions. Okay, so we're going to go through those conditions, and I'm giving you a lot of information here. You'll get a copy of the slides, and because I wrote this book, I've got all these references, so there's a lot of technical stuff, but I'll summarize it. So in the states that have been surveyed, 72 to 90% of cannabis patients list pain as a qualifying condition. It's very high. In some of the studies that specify what's the most common type of pain, like in this group of clinics back in 2006 when we did our survey, low back pain was the most common pain. I have to qualify that and say that, you know, back in those days, almost everybody's got a bad back at some point in their life. So people would come in wanting to get, you know, approved for cannabis, and that's a really common condition that they decided, you know, that's what they're going to use. I don't know that low back pain is the most common pain overall, but it was at that time. Okay. So we learned a lot about endocannabinoids and what cannabis can and cannot do for pain, but I want to elaborate. Earlier we learned that. So pain isn't pain until it reaches the brain. Prior to that, it's nociception. We already learned that THC and endocannabinoids are anti-nociceptive, so it decreases the pain signal from being interpreted in the brain as pain. That's one thing. When it gets to the brain, it also decreases that interpretation as well. Very important. But THC does that. CBD does not. They have very different effects and actions on pain. Both THC and CBD inhibit neurotoxicity and are neuroprotective and are antioxidants. So both of them do all those three things, making cannabis overall most effective for neuropathic pain and inflammatory pain. They're both anti-inflammatory as well. It's not on the slide. So in that case, both of those will inhibit neuropathic and inflammatory pain. But THC is the only one that changes the perception of the pain. Okay. THC has been shown to be analgesic, whereas CBD has been shown to be anti-hyperanalgesic. They're not the same. So for instance, CBD does not interact with opiates to decrease, to magnify analgesia. THC does that, CBD doesn't. Because CBD is analgesic, CBD is not. So overall, THC and CBD effective for neuropathic and inflammatory pain, THC effective for changing the perception of pain. Then we move on to chronic pain. This is where the mood effects of cannabis become so important. And almost all the studies on chronic pain show that cannabis-derived extracts are consistently referred to as improving the patient's quality of life. So typically, like in some of the studies done with multiple sclerosis pain, the pain scale only went down to a 7 on a scale of 10. That's only a 30% reduction in pain. But things like improved quality of life and improved sleep and improved mood, improved appetite, that's where you see a lot of the benefits of cannabis for chronic pain patients. Chronic pain is complex, and cannabis manages the pain in part by preventing peripheral nociception from reaching the brain, and when it does, it changes the perception. So overall, THC has been shown to be most effective for chronic versus acute pain because of these side benefits. CBD, everybody's trying to sell CBD as effective for pain. It's actually not as good as THC, but in fact, the mix, the THC-CBD mix, is really good. It's better than either one. So there's a lot of CBD out there that actually comes from hemp that has no THC with it, and that has, or very little, that has, sometimes it's extracted without a full spectrum extract. It doesn't have the terpenes. That's not nearly as effective for pain. If you're going to go buy some hemp CBD and expect it to take care of your pain, you're not likely to get as good a result as when you use a cannabis extract. This happens because a product of the synergy between all the different cannabinoids, the cannabinoid acids, the CBD, the THC, and the terpenes. Beta-caryophyllene is a primary terpene that is also anti-inflammatory, and it actually acts on CB1 receptors. So full spectrum extract is the way to go. Okay. Let me just back up for a minute. It's not my intention to give specific dosing and specific guidelines for how much you should use for what. These are generalized introductory comments. There will be more talks, clinical talks during the conference that might go into more specifics of what to use, how much to use. But I do want to emphasize that with chronic pain, you're going to use chronic doses of cannabis, and that amount is probably going to be a lot higher than someone that uses cannabis for acute pain on a very rarefied basis. A lot less will be effective in that case, whereas when you develop a tolerance, you're going to need higher doses. Okay, so in some studies, up to 71% of medical cannabis patients listed insomnia as their qualifying condition in those states where you could do that. And most of them, if they did list pain, also listed insomnia, because insomnia is a byproduct of chronic pain. So we have to treat sleep. Okay, it's complex. The effects of CBD and THC on sleep and which dose you use gives you the full spectrum of effects, from sedating to alerting to more sleep to less sleep to how long the effects will last. Can you take it every night? What happens if you take it every night? What happens to your overall sleep in the long term? It's really complex. I'm going to give you a few pointers here. THC, not cannabis, but THC itself, causes a decrease in REM sleep at low doses. That's what makes it so useful for PTSD, because it'll decrease nightmares, which happen in REM sleep. So that's a property of THC itself. And it increases deep sleep or slow wave sleep as well. These effects will diminish with tolerance. So many chronic cannabis users who use cannabis for sleep will find that it helps at the beginning, but not so much long term. One of the strategies that I used clinically was to keep THC at a lower dose, not use it every night to develop tolerance, use other herbal products like one night cannabis, one night valerian, let's say, and then, with some people with really bad sleep, one night their sleeping medicine. So instead of taking a sleeping pill every night, they're only taking it 2 to 3 times a week, which decreased their dependence on the sleeping medicine, and while not developing a tolerance to cannabis at the same time. As far as CBD, that's really good for anxious sleep. So if you're anxious before you get to sleep and you can't go to sleep because you're worried, that's where CBD comes in. But the dosage matters too. So very low doses of CBD, very low, it's not here, very low doses are not going to affect your sleep and may be anxiolytic. Moderate doses, I have to change this, may contribute to actual wakefulness. Whereas very high doses, such as in the kids that take 200 milligrams or something for epilepsy, they actually have a sedating effect. And somnolence is one of the side effects of very high doses of CBD. Wakefulness, moderate doses. Anti-anxiety, low doses. So this is an experiment that's very instructive. These were healthy volunteers, so we're not talking about people with tolerance. And this is just acute use. People without a tolerance to cannabis, they were given, not even cannabis, they were given THC and CBD. And 15 milligrams of THC increased the duration of slow wave sleep or deep sleep. Great. When they added CBD at low doses, 5 milligrams and 5 milligrams, there was a decrease in slow wave sleep, indicating that the CBD was somehow contributing what they called to wakefulness. Then at the highest doses, 15 milligrams of THC plus 15 milligrams of CBD, the wakefulness was increased, suggesting that in that range from 5 to 15 milligrams of CBD, you could actually be impairing sleep. But that's naive patients. So that's just to show you that, everything you do with cannabis is all about a homeostatic regulatory system, and you have to find that right, sweet spot for every individual. So a 1-to-1 mix is really good. And that's Sativex, which was that nabiximols that Dr. Sulak was talking about. And they also found that that increased sleep quality. People felt rested the next day. Whereas sometimes when they just use THC, as in the slide before, they were feeling groggy the next day and not as well rested. Even though they slept, they didn't feel as well rested. So this mix is really good for a good quality of sleep. Now, one of the things that happened in clinical practice is that people would smoke pot before they went to sleep, and they'd fall asleep great, and wake up in the middle of the night because they smoked, which lasts 2 to 6 hours of effect. So if you want to use cannabis to treat insomnia, it's best to use a longer-acting form, such as tinctures, capsules, edibles. Tinctures are my preference because they last from about 4 to 8 hours. Some edibles last more than 10 hours in some people, so you can really wake up groggy till noon the next day. And, the strategy that I did not like, which most uneducated patients do, is they'll smoke before they go to sleep, and then they'll wake up in the middle of the night and smoke again. So at most, they're usually only getting 4 hours of sleep, and we want to get, 4 hours of uninterrupted sleep at least. 6 is better. Okay. The last thing about sleep is that the most important thing to get good sleep is not the THC or CBD. The most important thing is the type of cultivar. It turns out that so-called indica strains, which is not used scientifically anymore, but the terpene profile, the strains that have a high amount of myrcene, which is a body relaxant and a sedative, are most effective for producing good sleep. Okay, now we're moving on to depression. And again, in some studies, we see that up to 50% of medical cannabis patients list depression as a qualifying condition. And I love this cartoon, I put it in. How do you feel the new antidepressant combo is working? I'll tell you, doc, I got a splitting headache, my tongue feels like dry leather, I can't hold anything down, I'm anxious, restless, and I lost my sex drive. Oh, good, it's working. And this is a prime example of harm reduction, because while they like to say that cannabis produces poor quality of sleep, or you might feel groggy the next day, which we can handle by dosage and delivery, it doesn't do all this stuff. So it's kind of a lot better than prescription medication. Okay, well, there are many studies that tried to link cannabis to a cause for depression. And these were done like in the 70s and the 80s. They used unspecified strains of cannabis with recreational users. And indeed, there are many strains of cannabis that can induce lethargy. And therefore, they can contribute to the symptoms of depression. So using the right cultivar is really important. Nevertheless, they were poorly designed studies. They didn't correct for confounding factors. And there are several studies that followed that show that long-term use of cannabis does not lead to an increase in depression. There are some studies that show that long-term use of cannabis lead to a decreased use of depression. And this very same accrediting society suggested that I include those studies, so in the updated slide deck, you'll get them in your references. The endocannabinoid deficiency syndrome that Dr. Sulek was talking about has also been implicated in depression. And there's a hypothesis that depressed patients have reduced levels of endocannabinoids. I mean, there's so many different causes for depression, but in some patients that are depressed, there are reduced levels of endocannabinoids. We also see that in fibromyalgia. We see it sometimes in migraine patients. So one of the ways that THC is really important for depression, not CBD, but THC, is that it primes the endocannabinoid system and gives it a boost. So they found that, as in most CBD1 dependent reactions, there is a biphasic dose. So what that means is that a biphasic curve related to dose. What that means is that low amounts of THC will have one effect, middle amounts will have another effect, and high amounts will have the opposite effect to the first one. So the dose with THC and depression has been found to be biphasic. So of course, there's conflicting studies because nobody measured the dose. So at low doses, you see antidepressant behavior, whereas in really high doses, you see the opposite effect. So again, every time you look at any study that's written about cannabis and any symptom, you have to remember that most cannabinoids act in a biphasic fashion, and the dosage and the chronicity is imperative to understand what the effects are going to be. They could be polar opposites. Okay. They did try to say that CBD has antidepressant effects, but look how high the animal studies had to go to find antidepressant effects. 50 milligrams per kilogram. In general, when someone, in my clinical experience, when someone says that CBD is helping their depression, they have anxious depression. It's really helping their anxiety. Because these kind of doses, I mean, the average dose of CBD that we use clinically might be 1 milligram per kilogram. So there's no way we're getting up to these doses. So CBD is not generally considered to be an antidepressant. But remember those pesky terpenes. If you have a cultivar that has a nice balanced mix of THC and CBD, and it has a very citrusy aroma that might be coming from the terpene limonene, the limonene is antidepressant. That's been proven action of limonene. So the strain that a person uses and the dosage is going to determine whether it's going to be an effective antidepressant. For example, a strain with myrcene, which I told you is sedating, you know, that might make a person feel like inertia, and they might call that depression. Okay. So we're moving on to anxiety. And again, it's really high up there, up to 58% listed as a qualifying condition. So starting with THC, there's very many conflicting reports about the effect of cannabis that's rich in THC on anxiety. Indeed, it's pretty well proven now that at low doses, any stimulation of the CB1 receptor is anxiolytic, anti-anxiety, including the effects of THC, whereas at higher doses, it's anxiogenic. So that's where you get THC causes paranoia. Well, that is definitely an exacerbation of anxiety. In general, clinically, I don't tend to go towards the higher THC cultivars for anxiety, but we do rely on CBD a lot for that because it's definitely antipsychotic and anti-anxiety at most doses, so that are clinically used. So you're going to look a lot towards CBD for anti-anxiety. If you do use THC, there's THC plus the terpene linalool, which smells like lavender. Linalool itself is anti-anxiety. If anybody's ever smelt essential oil of lavender, you just feel immediate ease. So you can use low doses of a THC-rich cultivar as long as there's linalool there, and that will be anti-anxiety. So they have done studies with CBD to see whether it has a bidirectional curve, the same as THC does. Unfortunately, the doses that these studies were done are not doses that we use clinically. One study started at 100 milligrams. Another study that I didn't even mention here started at 300 milligrams. So, if you do 100, 300, 900, you'll see that the 100 works. The middle one, the 300 doesn't work. And then the 900 works. Well, we already said that if you increase CBD to really high doses, you're going to see somnolence. And so, but clinically speaking, most of the doses of CBD we use are in the lower end of this, and you don't have to worry about dosage so much with CBD. They also found that CBD can counteract the anxiogenic effect of THC. So if you have a patient that is, dyed in the wool wanting to use THC for their anxiety, make sure that there's some CBD there. Okay. I have found that 10 to 18% list muscle spasm as a qualifying condition in the literature, but in clinical work, it's a lot higher. A lot of people have pulled muscles. A lot of people use cannabis topically to immediately alleviate a tight muscle. They don't necessarily go to a cannabis clinician and say, you know, I want to use cannabis because I pulled my muscle playing football. But it's a really common use of cannabis. Both THC and CBD are a muscle relaxant. So they do work by different mechanisms, so using both of them is really useful because you're targeting a multitude of receptors and you're not getting to saturation with either one. So if you want to treat muscle spasm, use both CBD and THC. And contrary to what you would expect, since it's so widely used clinically, there are very, 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 very few studies on muscle spasm and cannabis. As a matter of fact, I can honestly say that I really didn't find any for just regular muscle spasms. There was one in a paraplegic, there was one in a, secondary to chemotherapy, but this is an area that's highly understudied and it should really be researched. Now, in contrast to muscle spasm, there is a lot of information about cannabis and spasticity that actually is a neurologic symptom rather than a muscle contractility symptom. So there's a different mechanism. Most of these studies were done with multiple sclerosis patients who had muscle spasm. MUSIC trial, multiple sclerosis extract of cannabis trial in 2012, they found really strong rate of relief from muscle stiffness. 30%, twice as much as placebo. So cannabis is really good for spasticity. Unfortunately, you can't use it topically that effectively for spasticity because you have to get into the central nervous system. So you have to take it internally. And I have found that with my multiple sclerosis patients, that if they want to reduce their baclofen usage, you have to take cannabis internally. And other than that, topical's the way to go. Okay, now we get to a specific kind of pain. Most of the information that's available for cannabis is available for migraine. It's been classically used for migraine for centuries. It's listed in all the old 1800s and the old pharmacopoeias as to treat migraine, well known. Now, why is that? Well, headaches involve overactivation of the trigeminal vascular pathway, which is under endocannabinoid regulation. So we're not just dealing with pain, we're dealing with head pain. And as I said, endocannabinoids are intimately involved with that, and clinical endocannabinoid deficiency syndrome has been suggested as existing in migraine patients. And some studies have actually shown that in the brain of migraine patients, there are lower levels of circulating endocannabinoids. Not all. It depends on the chronicity of the migraine and where in the process that you're doing this measurement. Because migraine is a complex mechanism where there's an initial phase that involves vasodilation. Initial phase that involves vasoconstriction, and then a rebound phase that involves vasodilation. Now we know that THC is a vasodilator. So if you use it at the start of the migraine, when you're in the first phase, then you're going to be really successful. If you use it when your head's already throbbing and dilated, you may get pain relief because cannabis still will treat the pain, but you don't actually get a reversal of the migraine. So patients report that if cannabis is taken at the onset of the headache goes away, and that's actually really a true thing. Clinically, I saw that about 90% of the time. So I typically recommend that patients carry around a little vape pen that's high in THC. We're talking about THC cannabis here. And, if they feel a migraine coming on, just have a few puffs of that and it will reverse. Most of the time, that's true. There's another kind of headache that we should talk about, tension headaches. They can lead to a migraine. So if you feel any tension coming on in your temples or back of your neck, then you can immediately apply topical THC-rich cannabis, and it will mitigate the onset of the headache. Okay, so now we are going to talk about nausea. And nausea being under the regulation of the autonomic nervous system is one of those conditions that the dose and chronicity of cannabis use is, again, imperative. Over many of the dosages of cannabis, you will see antiemetic effects. You will see them with CBD, you'll see them with THC, you'll see it with CBD acid, you'll see it with CBG. So pretty much any cannabis is going to be really good for nausea, but we'll see before we're done here that if you take it repeatedly, you may get a paradoxical effect. So THC in the form of dronabinol was one of the first indications for a federally approved cannabinoid for the treatment of nausea. It's been approved since 1985 for chemotherapy-associated nausea and vomiting. And after that, following that, it was approved for HIV nausea. And so it's well known, THC is good for nausea. CBD came along later on, and hey, we found out that CBD is really good for nausea too, but it's thought to happen by a different mechanism. And again, we see the biphasic effect here. Even with CBD at higher doses, it can induce vomiting in animal studies. So one really good strategy here again is to use a mix, a CBD THC 1-to-1 mix for nausea, for vomiting, because they're both active. And then you don't build a tolerance to either one. And this is really important when we get to the paradoxical effect. So I do recommend a mix. Or if you can get CBDA, that's another good thing to mix with your CBD or THC. They all bind to different receptors. Okay. This loss of homeostasis by overusing an endocannabinoid regulator is a real problem with cannabis. And like if you use it for sleep and then after a while it stops working. If you use it for nausea and after a while it stops working, the next slide will show you what that might look like. So it's really important to use these strategies of mixing your cannabinoids and mixing chronicity so that you don't get in that category of using too much for too long and disrupt your own endocannabinoid system. Before we get to that, just to review. So if you're throwing up, obviously you're not going to be able to take your cannabis by swallowing it. Sometimes you can take a sublingual tincture and just spray it into the mouth. You can get an atomizer if you can't find a spray in a dispensary, but that's, comes on in 5 minutes. So that's one good way. You can smoke it, you can vaporize it, and there are some rectal preparations that, similar to compazine suppositories, that you can use for really strong cases where you need to get a lot in really fast. Okay, so what is the paradoxical effect of cannabinoids on nausea and vomiting? It's actually been given a name, cannabinoid hyperemesis syndrome. Most of the literature says that we don't really know what causes it except for chronic high use of THC-rich cannabis. But I don't know why they say they don't understand what causes it, because chronic high use of THC-rich cannabis is going to cause an endocannabinoid dysfunction. And so you get the opposite effect as you do in most biphasic reactions, where a low dose produces one response, the high dose produces the exact opposite response. So cannabinoid hyperemesis patients were found to use cannabis daily for at least 10 years. and they get into a paroxysm of vomiting that does not stop for days to a week. And there's only 2 treatments that they found useful so far, and that's to stand under a hot shower and let the hot water hit your chest wall. And I mean, patients with this syndrome actually stand under the hot shower a lot. It's a real thing, like every day, like 10 times a day. And they're also advised to cut cannabis out completely. I have a family member that experienced this, and I finally got him to get off cannabis. 3 or 4 years later, he thought, oh, I'm safe now. And then it started to happen again. So I am a holistically oriented practitioner and quite intuitive, and I examined him when he was, in one of these states. And it's interesting. This shows you personal variability. He's kind of like a type A and always really busy, and his heart was going fast, and he was kind of leaning forward like this, and his heart was beating against his chest wall, and he was really stressed. Of course, he's vomiting for hours. Of course, you're going to be really stressed. But I actually felt like his whole adrenal axis was thrown off as well, and he was experiencing medical chronic stress along with the vomiting. So I would think that if you find anti-stress mechanisms, they're actually going to reduce the duration of this cannabinoid hyperemesis syndrome as well. Okay, so cancer. I am putting this in here as a qualifying condition that you should know what to do and what not to do. Most of the patients that want to use cannabis in the condition of cancer use it to want to treat the symptoms of the cancer or cancer therapies. So it's actually a supportive treatment for symptoms, not for the cancer itself. We're going to talk about that in a minute. But the symptoms they're treating, nausea, vomiting, loss of appetite, poor mood, poor sleep, neuropathy from chemotherapy or radiation. It generally just lifts their mood, decreases pain, increases their food intake, and it's a really, really, really good thing to use to treat these symptoms. There's actually nothing else you can take that's going to do all those things. And you're talking about using typical clinical doses, which are not high, to treat those symptoms. And depending upon what it is, you can use a mix of CBD and THC. Depends on the mood. We already discussed that. Depends on the type of sleep. Depends upon the level of neuropathy. We're going to get to appetite in a minute. That requires THC. But this is a great quote from one of our great teachers, Dr. Donald Abrams, who used to teach at these conferences every year. He's recently retired from his integrative cancer book. For the cancer patient, cannabis has a number of potential benefits, especially for the management of symptoms. It's useful in combating anorexia, chemotherapy-induced nausea, vomiting, pain, insomnia, depression. It might be less potent than other available antiemetics, but for some patients, it's the only agent that works. And it is the only antiemetic that also increases appetite. Inhaled cannabis is more effective than placebo in ameliorating peripheral neuropathy in a number of conditions, and it could be useful in chemotherapy-induced neuropathy. Well, that's been proven that it is useful for that. Now, moving on to treating cancer, I've given this just one slide to tell you what not to do. As you practice clinically and you become known as a cannabis clinician specialist, there will be patients that come in and say, nothing else has worked, I want to use cannabis for my cancer. And I read about Rick Simpson oil, and I need somebody to help me do this. Rick Simpson oil is a high-potency, THC-rich cannabis oil extract, where the protocol involves using like 800 to 1,000 milligrams a day for 3 months. Clinically, we use maybe 5 to 25 milligrams as a dose of cannabinoids in our cannabis, so this is like way up there. And I personally have treated many cancer patients as an anti-cancer therapy, but I would not recommend that anybody do that nor encourage it unless you're really proficient at this and a lot of conditions are met with your patient. It's very expensive and it's very complex. Please don't do it. But we do know that cannabis, including THC, CBD, THCV, CBG, there's about 10 more that are really up there in cell culture and in animal studies that are anti-tumorigenic. They will actually decrease the growth of the tumor. So there's potential there. But again, nobody wants to use those doses unless they're really qualified with it. So that's pretty much it for cancer. Then we're going to go on to anorexia. So anorexia itself, loss of appetite, is not necessarily the primary condition for which patients seek cannabis, but is often a component of many chronic illness conditions for which the patients are seeking cannabis. So we need to understand how cannabis works in appetite regulation. So there are many conditions which patients use cannabis for to stimulate their appetite, not just in chemotherapy or HIV/AIDS, but disinterest in food. Taking too many stimulants. I have many patients that are on stimulants for ADHD that actually are experiencing weight loss. And cannabis provides a useful alternative to the stimulants, both for the ADHD and for stimulating appetite. A special case happens with anorexia nervosa, and we will review that, because THC isn't that helpful for that, because that's anxious, anxiety-induced lack of appetite. THC does not help anxiety-induced anything, unless it's in a minuscule dose, like we talked about before, very low doses. So we know that the endocannabinoid system is intricately involved in the regulation of hunger hormones, and that the patient's genotype is highly important in determining how an individual person will respond to cannabis and how it affects their appetite. Some people get the munchies, and they really have cravings, and some people can have cannabis, no big deal. I have another family member that had high consumption of cannabis for a very long time, and she recently stopped, and within 2 months she gained 20 pounds. So that's the exact opposite that you would expect. You would expect the cannabis to be stimulating appetite. Well, in her case, because she took it for so long, not only was her appetite lower on the cannabis, but her metabolism storage was lower. Her fat storage was lower on the cannabis as soon as that came off, because you can get a severely disordered endocannabinoid system if chronic use of high-dose THC. Don't do it. Okay, so the stimulating effective THC has been found, again, to be biphasic. Low doses stimulate appetite. High doses decrease feeding, which is what we find clinically. CBD, on the other hand, does not actually stimulate appetite. In some cases, it may be appetite suppressant. But in the particular case of anorexia nervosa patients, it's really useful in treating the anxiety that's interfering with the body's ability to feel permission to eat. So they've done some studies, modest reports, with most patients. In most studies, we don't see a big effect on weight gain or appetite stimulation over the long term in any study that's ever been done. You don't see a lot of really overweight, high-use cannabis people walking around. And so that's, again, the issue of tolerance. So if you're going to use cannabis to stimulate appetite, you have to stay at the lower dose range and use intermittent dosing, like 1 or 2 puffs of a vape pen, which is rich in THC, before a meal. That's good. That's 6 puffs a day. Nobody's going to develop a tolerance. But having an edible 3 times a day, keeping your body saturated in THC, you're not even going to eat more. And that's what's been found. Even in the case of anorexia nervosa patients, they found minimal weight gain. Unfortunately, I was not able to find a study that actually measured weight in anorexia nervosa patients who took CBD-rich cannabis. Maybe there is one out there. I wasn't able to find it. That's something that should be done. And then we get back to our pesky terpenes, and it turns out there are certain cultivars that have a terpene called umulene, which is also found in hops. Doesn't really have much of an odor, but that's an appetite suppressant. So if you're wanting to use THC for various other reasons and you don't want to mess with the appetite or the eating, look for a cultivar with umulene. And our last one is going to be PTSD. So depending upon whether it's listed as a condition, PTSD is classically used to cannabis is classically used to treat PTSD for the variety of positive effects it has, including decrease in nightmares, decrease in arousal, decrease in stress, change in perception, and something they don't really talk about, which is, well, decrease in perception also has to include an escape mechanism. It really changes one's perception of reality, which is why most people with PTSD really prefer high THC rich strains, because it changes their perception of their reality. On the other hand, the cannabinoid THCV, which does almost all those good things, decrease arousal, decrease stress, is really useful for PTSD patients, but it doesn't change their perception. They don't like it, but it really treats symptomatology of PTSD very effectively, and as that cannabinoid becomes more highly available, I would strongly urge patients to look for that for PTSD. So confounding from many studies have tried to indicate that patients with PTSD have increased diagnosis of cannabis use disorder. And many of these people have been diagnosed as cannabis use disorder abusing the product. They're actually using it as a medicine, and that's another whole thing, but I'll give you one sentence. In diagnosing cannabis use disorder, some of the criteria that you have to meet is craving for the substance, using it daily, becoming altered from it. Well, these are the effects of medicines most often. Using it daily, wanting to do anything to get their medicine. Well, what if you're taking blood pressure medicine? You're going to want to use it daily. Your blood pressure is going to be too high. So you have to be really careful with cannabis use disorder and its association over the past 30, 40 years with patients using cannabis. So fortunately, the Veterans Administration has issued a new policy as of December 2017. So I'm practicing for like 10 years before this. And the vets would come in and they'd say, you can't put this in my record. And we can't let the VA know that I'm seeing you, because they'll deny me service, they'll take me off my opiates, and I'll lose my benefits. Well, they actually changed their policy in 2017 and said veterans must not be denied VHA services solely because they are participating in state-approved marijuana programs. We medically, we call cannabis cannabis. But, Yeah, but in paradigms that still consider it a drug of abuse, they'll call it marijuana. Okay, so an important corollary to that decision is cannabis use should never ordinarily be considered a disorder. First, it's a medicine. If you're using your medicine improperly, that's not a disorder. That's a lack of education and communication and patient compliance. And those are all things that must be monitored. So in summary, become trained in the effects and dosing of cannabis for the qualifying conditions in your patient population. Pain is the most common condition for which patients use cannabis. THC is analgesic. CBD and THC are anti-inflammatory and, whoops, lost that word, anti-neuropathic. Insomnia is common for cannabis. Consider THC rich with myrcene. Depression and anxiety are often co-diagnosed. Know what you're treating. If it's THC, if it's depression, you're going to look towards THC, the appropriate cultivar. If it's anxiety, you're going to look towards CBD, the appropriate cultivar. Muscle spasm responds to both THC and CBD. Spasticity requires internal use. Headaches use THC at the start of the migraine. Topicals are really good for tension. Nausea, vomiting, many cannabinoids are effective. THC, CBD, CBDA. Cancer. Cannabis is most often indicated to treat the symptoms of the cancer or the cancer treatment. Anorexia. THC is good to stimulate appetite. CBD is good as an anxiolytic for anorexia nervosa. In PTSD, both THC and THCV regulate the stress response, as in decrease it. But THC in particular helps to reduce nightmares. Thank you. The references are not on this slide, but we have them because there's too many. There's like 70. And remember, you can't spell healthcare without THC.